Hey guys, my name's Austin, and I'm currently a medical student rotating with Dr. Benzur. Today I'm going to go over some ACLS cases with you. And the first one we're going to go over is going to involve a pulseless patient and an adult cardiac arrest. So with this case, in the algorithm we're going to go through, it's going to outline the assessment and management for the steps of the pulseless patient who does not initially respond to basic life support. So first, of course, you're going to shout for help and activate emergency response. So you're going to start CPR by pushing hard about greater or equal to 2 inches, so about 5 centimeters, and at a fast rate, so about 100 or more compressions per minute. And always make sure to allow for complete chest recoil during each push. So you also want to minimize interruptions in these compressions and avoid excessive ventilation. So during this time, you're also going to give the patient oxygen and attach a monitor and defibrillator. So the most important thing in this algorithm is to determine if the rhythm that the pulseless patient presents with is shockable. So the rhythm you can see here is actually VTAC. So you can see the wide complex QRS here. It's a pretty regular rhythm as well. So regular wide QRS, and it's also tachycardic. So you can see the rate is about 150, maybe 130. So this is going to be, like I said, VTAC, and this is a shockable rhythm. The other shockable rhythm you want to be aware of is VFib, which is right here. So with VFib, you can see it's very irregular. Once again, there's wide QRS, no P waves present, and this is another shockable rhythm. So the other things you want to be aware of is asystole, which is basically going to be a flat line, and this is not a shockable rhythm because there is no cardiac activity or electrical activity going on in the heart. So once you determine whether or not the rhythm is shockable, you will then proceed a certain way. So if you have VTAC or VFib, you will shock the patient, and the shock will usually be at about 120 to 200 joules, close to the maximum. And so once you shock, you will then do CPR for another 2 minutes. And if you notice the patient is still not recovered, you will shock another time. So shock for a second time. Then you will also then return to CPR for another 2 minutes. And also at this time you can add epinephrine for every 3 to 5 minutes. So you determine, just to recap, determine you have a shockable rhythm, VT or VFib. You'll do CPR for about 2 minutes. Then you'll shock again, and then do CPR for 2 minutes. And at this time you can add epinephrine. So after the second shock is when you then add epinephrine. And then if the patient's still in this VT or VTAC, you can shock for a third time, and then after the third shock, you will add amiodarone. And the amiodarone is usually going to be IV dose, first dose about 300 milligram bolus, and the second dose would be 150 milligrams. And to go back, the epinephrine that we give is 1 milligrams every 3 to 5 minutes, whereas the amiodarone is going to be the one-time dose. And then you will go back to possibly shocking the patient if they're still in this VTAC, and repeat that cycle of going through shock, CPR, epinephrine every 3 to 5 minutes, then shock, amiodarone, and that will be the typical pattern you will go through. And so that is for VTAC, VFib, the shockable rhythms. And now if the patient has asystole or a flat line, you will not shock the patient, but you will go straight to epinephrine every 3 to 5 minutes, 1 milligram. And once again, you will determine, constantly looking at the EKG monitor to determine whether or not the whether or not the rhythm changes during this treatment. And so that's very important, once again, to monitor the activity of the heart during this process.